Good morning, good morning, good morning. How is everyone doing? What's up, boys and girls, ladies and gentlemen? We've had an awesome weekend. Obviously today, the announcement from the government comes out on whether we go from level 3 to level 2 this week or they extend it further. So everyone's waiting with bated breath there. I thought I'd bring on a guest onto the show who knows all the science behind what's happening. She's a medical doctor and researcher and works over in the UK for the NHS. Who better to have on board during this time than the one, the only, Dr. Natasha Matthews.
Hello.
How are you?
I'm good, thank you, Jason. Thank you very much for having me. It's a pleasure. And how are you?
No worries. Oh, fantastic. It's good to have you here. We haven't seen each other in a while. It's probably been a few years now, face to face, but you're a champion, so it's awesome to have you on the show. I thought we'd go through some of the science and then talk about how the NHS is doing, how everything's going over there. But before we do, give the quick 5 on your background, your history, and how you came to be here, just for a bit of context for everyone.
I will do that. Before I do that, though, I'll just give the disclaimer that I am by no means a public health expert, but I am very happy to give my opinion on how things have seemed to me on the ground and just what I've learned from the reading I've done.
Perfect.
So a little bit about me. So yeah, I'm a junior doctor from the UK, and Jase, as you know, you and I met in New Zealand. And to be honest, that's quite fundamental, to be honest, to what has influenced my journey, because when I was in New Zealand, you and I both took some population health classes together. And if you remember, we learned a bit about health inequalities. I don't know if you remember, do you remember Rod Jackson, the lecturer?
Yeah, the butter guy.
Yeah, the butter guy. So yeah, the butter guy really influenced me, actually. And as did some of the modules we took. We watched Sicko, I remember, which is that documentary on the US health system and comparing different health systems. And so that gave me my first insight into kind of health inequalities. And I had a lot of interest in that. And then I went on later to start medical school in the UK. I went to the Hull York Medical School, which is split between 2 very different regions in the UK. Hull, which is quite a socioeconomically deprived area, and York, which is more affluent. And so there was a big emphasis in our curriculum on health inequalities. So I became very interested and passionate about health inequity. And I joined, as I've mentioned in the bio, a global health student group, which I hold very dearly, called Students for Global Health. But then it was known as Medicine UK. So I kind of started that because, having had my international health experience in New Zealand, I thought it was a valuable experience for anyone. And the organisation I joined ran these international exchanges where you can do clinical placements abroad. And so I wanted to be able to organise that. And so I started to look into doing that locally. And it's through this, so Medicine UK, or now Students for Global Health, is part of, you might already know about it, I'm not sure, but it's like a network of medical students associations called the International Federation of Medical Students Association. It's a mouthful. New Zealand's got Say again?
I don't know it.
Oh, right. Well, yeah, basically, you might in future. So New Zealand's got a medical student organisation itself, and the UK has one, and that's what Students for Global Health was. And they organised one of the largest exchange programs worldwide. So that's kind of how I got involved in that, which was really cool. And I developed a broader interest in sort of not just clinical placements where you go to other countries, but global health education programs, more specifically at home and abroad, and also ethical electives and the ethics of placements. And that kind of formed some of my early research interest. I took on a few leadership roles in Medicine UK, including I ended up being what we called Director of International Affairs, that maintains the link with the IFMSA. That's easier to say than the full title. And just if any medical students happen to be watching this, I would just recommend that you get involved, New Zealand medical students, with this organisation, because it's really great. I got to meet a lot of interesting individuals from different countries, including New Zealand, and it gave me lots of new perspectives on health issues and was very inspiring. So yeah, that's that. Yeah, I took a break after that, and went on to do more formal study at university on global health. where I did a research project looking at global health education across the UK. And then I finally went back to clinical medicine, graduated in 2018, and now I'm doing a mix of clinical and research work as an academic foundation programme doctor in the northeast of England, which is fun. My research interests include global health education, which I can talk a lot about, but also I've done some more recent projects on elderly health, mental health, and also climate change and health, and those are kind of areas.
How come you came to New Zealand originally? It's about as far away from the UK as possible.
Well, so it's a complicated story. So, well,
we've got time.
So again, we've got time. Yeah. Well, the first reason I came is because my dad grew up in New Zealand, and we thought when I was looking at going to do medical studies that I would consider New Zealand as an option. And so the way it worked was that I had to start my studies in New Zealand in February, because that's the beginning of your year, isn't it? Yeah, while waiting for my sort of confirmation of my offers from the UK for medical school. And it was kind of crazy. A lot of my friends are like, that was a weird thing to do. But I thought, you know what, I'll start because it will be cool. And then I'll see what happens.
You're sort of hedging your bets and like getting a head start on the UK medical school system and doing a bit of pre-readings in New Zealand for when you entered medical school in the UK.
Well, yeah, and I was on my I spent the first half of my gap year I worked and made money, and I worked as a research assistant actually in a psychiatric hospital, and then when it came to February, I was like, this will also be fun. It's kind of maybe a strange thing to do, to study on your gap year, but I think it was definitely helpful in kind of framing my medical school career. And yeah, it was very sad when I had to leave though. So
neat. We also have the one and only Jordan Hinton tuning in.
Hello, Jordan.
Woohoo. Love these two. Hey, Jordan, you're a champ. Good to see you. So let's jump into the chunky stuff, the science behind everything. Why is this virus so much worse than other viruses? And okay, let's start at the top. What is a virus? How does it work? And then we'll discuss why is this one so much worse than others that we've encountered before.
Right. Okay. So a virus is a specific kind of infective organism that we can catch, and coronavirus in particular, or this novel coronavirus, you'll probably have seen this. People have seen this in the news, but it spreads via droplets. So they come into our body in some way and they make us sick. And this one is a bit unknown. So they know it spreads by droplets and aerosols, but as far as I know, the research around the latter is a bit more unknown. But yeah, those are the basics. It's a pathogen that makes you sick. It comes into the body. Yeah.
And so why is it worse than other viruses that are out there?
So a number of factors, and it's an interesting one. It seems to be very contagious, so that's one thing. And before I did this, I looked up some of the numbers to share with you. So
perfect.
There's this statistic that people use when looking at disease transmission called R0, and what it means is the average number of successful transmissions per case in a entirely susceptible population. And that is how epidemiologists and such like kind of look at how contagious a virus may be. And they use some of the data from Wuhan, where the virus originated, and they've estimated, and it's not a static thing, but they've estimated it's about 1.5 to 4.5, which is a similar range to SARS, Ebola, and seasonal flu. So yeah, that's those diseases. It just happens to be quite contagious. But more specifically, there's this possibility that asymptomatic carriers are contagious too, not just people displaying symptoms. Yeah, so that's made it very difficult to contain. Because so you have the incubation period, which for those who don't know is when the virus is there but you're not necessarily displaying symptoms, and transmission can happen during that period. This is unlike SARS, where people became infectious but only after developing symptoms, so it was easier to know who to quarantine.
And that's why all the measures have come up, lockdowns and people closing borders and all the rest of it.
Yes. And the other thing is the long incubation period of the virus. So again, I looked this up for you, and it's estimated, there's a few different figures. Some say 5, but I know what we've based UK public health policy is the range of 2 to 14 days. Which means by the time someone has symptoms or is tested positive, they could have affected many other people. So obviously that's a problem. And as of now, I think anyway, the research available is quite unclear on how long people remain infectious for after recovery. So that's something that needs to be looked into. Yeah. Another big issue is it seems to affect patients who have existing health conditions. And then it attacks the immune system, leading to high morbidity and mortality. So anecdotally, from some anaesthetics colleagues that are working in ICU at the moment in the UK, the typical patient profile that seems to be needing ventilation is sort of middle-aged to older, diabetic and a BMI over 30, so obese. So that's obviously a problem in a population which nowadays in high-income countries we have huge amounts of diabetes and obesity. The other thing is elderly patients. They're really vulnerable, and a lot of countries don't have the health and social care infrastructure for the elderly to cope with something like this. Yeah. And just having said all that, because you've asked, it is interesting though, because actually this virus has a case fatality rate estimated at 2%, so that's 1 in 50. And I looked up the comparisons with some of the other viruses that have caused sort of inter-country effect, and so like SARS and MERS. And with SARS in 2002, it was 1 in 10, and MERS in 2012 greater than 1/3. So yeah, I think the key thing though that's different between these viruses is, again, I'm not an expert, but is that the fact of what I've discussed about asymptomatic people being able to transmit it and long incubation periods.
Yeah, right. There's obviously a lot of panic around the world, especially with people who don't understand it, or there's a lot of media coverage around everything that's happening, and that sort of escalated the whole situation to an extent. Obviously there is the medical side and you understand that inside out, but how do you feel the response has been? Has it been an over response, or are we taking this thing very seriously because it needs to be taken seriously?
Do you mean sort of globally or in the UK?
Globally, obviously this is unprecedented.
We can see by the global death rate that it's serious.
Yeah.
So I think we are taking it seriously because it is serious. And I think the countries, you can see a pattern, the countries that have acted fast and they've imposed quite draconian measures, New Zealand being one of them, have had very low, not always, but it seems to be a pattern that I've seen anyway. They seem to have done better with responding to the virus. So I definitely don't think it's an overreaction. Yeah. Fair
enough. Do you think that like other viruses like the flu will have a rise in cases just during winter, or it may be too early to tell that yet?
Yeah, so this has been something that I've read about actually, because it seems to be conflicting evidence on this at the moment, because I don't believe there's a clear pattern of higher rates of infection being associated with lower temperatures. I guess an example would be Australia, where obviously we're opposite in terms of seasons at the minute, but they still were showing an increasing trajectory like the UK. So that makes me think as well, lower temperatures might not make much of a difference. However, I think what we do know is if we do have a second wave at the same time as seasonal flu, which obviously tends to happen in the winter months, health systems will be seriously challenged to cope. Yeah,
right. Like there's people are getting, I guess, a little anxious here. They've been in lockdown for quite a while. They want to get back into a swing of things, this new normal. The government is sending out messages that everyone should stay at home still. We've got an announcement today by the PM on whether we can drop our escalation level or alert level down to level 2 this week.
Coming today, so it's not happened yet.
No, it's not happened yet. No. So we're still waiting. So yeah, fingers crossed. But obviously, the health data has to line up with that. Do you? I guess with people getting
we just had our this evening at 7 p.m. We just had our kind of big announcement, but there's been criticism of it already.
Oh, really? What happened in their announcement?
So basically, Boris Johnson has started to discuss loosening of lockdown. And so it's looking at, we're going to move from level 4 to 3 in the 5-tier system you mentioned earlier. And so key changes that he's talked about is people are being encouraged to return to the workplace if they can't work from home. So like construction workers. Also, we're supposed to avoid public transport. Schools are going to apparently reopen as early as the 1st of June, but that he's sort of caveated that by saying it couldn't possibly be earlier than that. We've got unlimited exercise as well, which if you were here, you would appreciate. Yeah,
love that.
Because people were doing, I think, with that. That was a big thing, and they had like police telling people off in parks and stuff, and it was all a bit intense. But yeah, so unlimited exercise, and now they're saying that we can meet one person outside in a park if you maintain social distancing. So that's good for people who live alone and stuff, who I've really felt for during all of this.
So that's pretty similar to our level 2. All of our gyms are allowed to open with tracing. So yeah, it's good for me. I love that stuff. So do you think with people getting more anxious if we can't get down to that level? Obviously, the announcement hasn't been made yet. That we'll see a second wave almost of all this happening, just because people will start to maybe interact a little bit more even when they're not meant to. Obviously, this is a New Zealand case, but I guess this is similar all around the world, depending on what's happening from country to country.
Yeah, I mean, that's a tricky one. Big question. What I do know is that there's been a lot of, I saw a lot of articles warning the problems with easing the lockdown too quickly. Because I think, I don't know, from what I can see anyway, again, not being an expert, but from the UK is that we not arguably acted very late. Our government acted late, not necessarily had the best leadership on this. And
Boris Johnson even got COVID, didn't he?
He did get COVID, he did, and now he's well, so that's good.
Now he loves the NHS.
yes. But I mean, I do feel that, we could have acted quicker and that would prevent things. So that makes me think that by loosening lockdown measures too quickly, you could perhaps see a trajectory similar to the UK, where things are allowed to get the coronavirus will run rife amongst the population, and then suddenly you're out of the containment phase and you're trying to mitigate desperately. I feel like our health system just about coped, really. So
yeah, what do you think we're any closer to getting a cure or vaccine? What's the world doing in that regard?
Right, so I do think so, but I think it's going to be time. So there's actually over 100 groups working on the vaccine internationally, which is amazing. And the UK and China has actually started human trials already.
Oh, wow.
So that's very cool. In terms of it being widely available, I don't think anyone knows a date as of yet, but I think a common guess I've seen for a good outcome is May 2021. So that's... Okay,
so roughly a year.
Yeah. There's actually, for anybody listening now or afterwards, there's actually quite a cool tool that the London School of Hygiene and Tropical Medicine have developed. It's a vaccine tracker. I can link it. I can put some links after this, can't I, in case people want to do further reading.
Is it on the website? We can bring it up.
Oh, do you want to? Oh, okay. Do you want me to find you the link?
I'll grab it.
You can need to Google it. Yeah. So NSHGM vaccine tracker is pretty cool.
So jumping on Google now, is it the top link? COVID-19 vaccine tracker. Let's click into it and see what happens.
I don't know if that's the LSHTM one. No, that doesn't look like it. I actually came across it on Twitter.
That's all good. We can pull it up afterwards and link it into the show.
Sure. So yeah, but I can tell you briefly what it shows. I think there's several in phase 1. So that's vaccine trials on humans, and there's one in phase 2. So that's on a larger group, often more than several hundred humans. So that's pretty cool. From my own experience working, one of the trials I'm aware of, which is one of the UK phase 1 trials, is the recovery trial, or it's quite cool. It's randomized evaluation of COVID-19 therapy and the recovery. So that's looking at a range of potential treatments. And they've kind of started putting that out across, I think they've got like over 170 sites now in the UK, including my hospital, which is quite cool. So they're looking at a few different things like antiretrovirals that we use to treat for HIV commonly. Steroids and some antibiotics. You've probably seen all the clips of like Trump going on about hydroxychloroquine.
Yep.
Yeah. Yeah. So, and some of the antiretrovirals. So they're doing the testing hydroxychloroquine to actually see if there's any evidence there.
Is there any science behind that, or is he just ranting?
No, I believe there's science behind it. I don't actually know the details myself, but for it to have, like from what I know of the recovery trial, it's all based off like initial hypotheses that have some kind of biologically sound thinking behind them. Yeah, I think he was saying the way he was coming across was like, we just all need this thing, and like it's fine, like just try this thing, and it's like, wait a minute.
There's so much stuff that he comes out with. Everyone's like, oh, this is the Donald Trump show. Okay, what kind of crazy is he coming out with today? So, like, he might be speaking truth, but no one knows. No one knows.
No, yeah. I think it's part of his brand. People love it. I don't know. But there really is quite a funny YouTube like compilation that I saw that's called like Donald Trump, I'm not a doctor. And it's just him being like, I'm not a doctor, and just saying all this like clinical advice and following it up with crazy statements. So yeah, that's funny. Can link that too. But yeah, there was one other thing actually I was going to mention, which is kind of crazy that I read, that was there was a study that actually showed that smoking daily led to less severe disease. And this is, as you can imagine, is like being interpreted with a lot of caution, and there's a lot of follow-up studies. But that's led to them trying the nicotine replacement therapy in COVID-19 patients to see if that helps outcomes. So that's pretty. So
they're testing heaps of stuff. Like,
yeah.
There's no limits on this thing.
Yeah, so in my the trauma meeting, so I didn't mention, but I earlier, but in the bio, I work in trauma and orthopaedics at the moment. But in our trauma meeting room, we've got, because we're being asked like to, like refer people for the trial if we think they're candidates. There's just this like thick wadge being like recovery trial, like here, read, like think, and it's got a huge list of stuff, and some of it's really weird and wonderful. Like we don't have it at our hospital because I don't work at like a tertiary center with lots of specializations, but they have some strange stuff that would be at sort of bigger hospitals that they're trialing. Yeah,
wow. Also, if people get COVID or they just have symptoms, what happens to them once they go through the system? If they arrive on the hospital doorsteps, and then what happens from the patient point of view? How did they get tested? What happens if they're COVID positive?
Yeah. So this has changed loads since so it's been kind of mad. Like my current rota has gaps in it sometimes because they would make us work like a lot of on-call shifts on nights, and then we'll get like mandatory time off. So I've had this weird experience over March to now where like I've gone away for a few days and then suddenly come back and like it's been entirely different, and one ward has been closed, or like we're actually expected to do this thing differently. But at the moment, what we're doing is it's on orthopedics specifically, is any patient that we're referring into hospital for an orthopedic problem or possible surgery, they all have to go first to something called the surgical decision unit. And it's basically a ward that's been deemed like dirty, which is a phrase that they're using to mean like lots of COVID or possible COVID patients, and it's like not a sterile ward. and they get 2 swabs now, and once they're cleared COVID negative, they either go to our clean ward or they go to the COVID-19 positive ward on orthopedics. But that's like a new thing, and they're testing everybody who comes to hospital, whether they have symptoms or not. So that's interesting.
Oh, wow.
And that took a long time to happen.
I think because they have the equipment now to do so?
I think that, I'm not sure.
Or just change the procedure?
I think that was the sensible thing to do always, given what we talked about the virus earlier and the fact that, you know, asymptomatic, etc. However, I think it probably was to do with scaling up of the relevant diagnostics, I'm guessing, because there's been so much talk since all of this started about scaling up testing, and, you know, other European countries seems to have done a lot better. But for some reason in the UK, we're kind of lagging behind a little bit. I think there was some thought behind that, was that because the tests have is not entirely got 100% sensitivity and specificity, it might be better just to tell everyone to isolate if they've got the symptoms, as opposed to testing them and basing off that. But then we had the issue that healthcare workers aren't tested, and so it gave a lot of healthcare workers, including myself, concerns when you're going into work and you're feeling, oh, I've had a bit of a viral illness. Could this just be me, like, having mild symptoms, and I'm just like spreading it amongst all these like elderly, unwell patients? So yeah, still not routinely testing the health workforce in my trust, or I don't think anywhere actually, but they're definitely scaling up. I think we're on 1 million now in the UK that have been tested. That's patients.
Oh, wow. Big chunk of people.
For you guys, maybe.
Yeah, that's true.
Yeah. But no, I think it should be more. Countries have done a lot more. Yeah. So that's what we're doing at the minute. Is, sorry, back to your initial question, is testing everybody. In terms of you coming to hospital with symptoms and you seem unwell with coronavirus, again, you'll get swabbed, etc. You'll go to a medical ward, and there's kind of different levels of wards depending on patient profile, likely outcome, things like that. So yeah, there's a ward for people who are likely to have kind of escalated measures of high flow oxygen and stuff, and then obviously there's like our HD, the step below ICU, and then intensive care, where people are on ventilation and things. So
it's an interesting time, especially for the hospitals, obviously, where like it's so fresh that everything can change in an instant. I just want to shift focus slightly to the global systems and what's happening at the top level. What does the World Health Organization do generally, and how are they managing this crazy situation?
Yeah, so I knew you were going to ask me this. So I do, as much as I love to talk about the WHO, that's a huge question. So very big topic, but certainly I think in the scope of this, we can talk about the role kind of in pandemic response, which I think is a fundamental role of the WHO, in terms of international coordination of the kind of global pandemic response effort, and also supporting countries at the country level or regional level, etc. So yeah, that's kind of making things a bit more specific. But yeah, in terms of what they're doing about the whole global pandemic, the first kind of key role, I would say, of the WHO is actually to carry out a situation assessment of a potential threat. So reviewing all the epidemiological situation, evidence, and providing a risk assessment. So things like the likelihood of further spread, the potential impact on health, effectiveness of preparedness and response measures. So yeah, that kind of stuff. And what the WHO does is, and they have done in the past for things like Ebola, etc., is develop an emergency committee, which is essentially experts from different regions. So the WHO has got 6 different regions. So it brings them in, and the Director General sort of selects people that are put forward by each region for consultation, and they consult and they advise whether or not something's what they call a public health emergency of international concern. And basically that's what's happened on the 30th of January when they kind of announced it. Yeah. And then once they mobilized all the efforts, I'm just signposting there's going to be a bit of bureaucratic chat now because that's WHO. Yeah. So they developed an international strategic response strategy, and this has three objectives. So the first one was international coordination. So that's on delivering technical and operational support. So things like surveillance countrywide. The second one was scaling up of country preparedness and response operations. So that's kind of things like country readiness to rapidly detect, treat cases, and also kind of making sure all countries have the right infection control measures in place. Third thing's accelerating priority research and innovation. So that's fast tracking the research that's going to allow the availability of effective treatment, vaccines and diagnostics. So yeah, that's kind of their strategy. There's a complicated bureaucratic structure within the WHO and the United Nations, the WHO being like the health body under the UN structure, and that's sort of how they carry out this international coordination that I've mentioned. I couldn't possibly go into all the levels. There's diagrams.
Yeah. It's a huge organization. They do a big job.
Yeah. And it's just like that. It's one of those organizations that you like unpick and it just gets more and more mysterious. But essentially it's done via a system of what they call incident management support teams. And they've got that at the global level in Geneva, in all the 6 regions, and also at the country level. I also read that they've got this body called the UN Crisis Management Team, and that was established on the 11th of February, and that focuses on, at the global level, communicating key information, analysis and prioritization of key emerging issues, and also sort of policy decisions and joint action plans, etc. And again, they support at the country level to make sure that they've got the right sort of effective pandemic response plans in place and things like that.
Yeah, so they put together the big overview framework, send it out, put it out to all the countries and governments, and then it's the government's responsibility to pretty much make sure it happens.
Yeah, so that's an important point to mention, actually. What you just said is it's kind of the country, government responsibility again, but the WHO does partner with organizations in different countries and help scale up in sort of lower resource settings where they might need help with like accessing the diagnostics, etc. But it's quite a fundamental organization in the way that it allows this coordination globally, and it's pretty key when it comes to addressing something like this, because it's important that countries are sharing information and they're working together. And it allows that kind of sense of solidarity between countries. And also just with the fact that they coordinate information sharing, the WHO actually makes really useful sort of available data for public. So this really quite useful source that I've looked at from time to time is the WHO kind of daily updates. And they just give you like key things around the world that have happened on coronavirus. And it's quite helpful if you're wanting to keep abreast of what's going on. Yeah,
it's certainly helpful for, I guess, all that information to get shared without it being politicized, and because there's a lot of kindergarten antics that happen in the background of politics that it's just trying to, everywhere. There's good politicians, don't get me wrong, to try and rise above it, but on both sides of the spectrum, left, right, it doesn't matter. People will always take jabs at each other. It's just the game of politics.
I just want to feel like things are more civilized in New Zealand. I just feel like things are more civilized in New Zealand compared to our like Houses of Parliament, but I don't know. I don't really keep track. So.
Globally, I think we're pretty good in the relative scheme of things, but you always have people throwing punches that aren't needed, and I think it causes for a bunch of inefficiencies, but that's for another talk. How has Europe and the UK responded to all this in terms of, I guess, New Zealand? It's very easy to isolate all our citizens because we're just on a few islands, and we can pretty much shut ourselves out from the rest of the world. But Europe's a huge continent, and there has to be, I guess, all this intergovernment response, and they have to make sure everything is coordinated, and people can just cross the border by walking. How can they manage such a huge beast on such a big landmass?
Yeah, big question. I like it. So I think Europe's
General
an interesting one. Europe has shown different patterns within the same continent, as I'm sure you know. So it's kind of, I think, broadly split into two groups. So you've got countries like Italy, Spain, the UK, France, Belgium, all affected very badly, with high mortality, particularly in the poorer sections of the population and in elderly. Health systems, like I said, I feel like in the UK we're just about coped because we're past the peak, reportedly. And it's unclear what percentage of the population have been affected, but I think I read like about 10 to 30% in those countries where it's been worse. But yeah, you'd have to check that. It should become clearer in the next fortnight, I would imagine. And all those countries of lockdown society now gradually reopening. I mentioned that Bojo did an announcement this evening. So yeah, those. It's unclear if we'll have subsequent waves of infection and how they will be handled, and if new testing and contact tracing programs linked to smartphone apps, that's one thing I've read about, will actually be more effective. So yeah, I'm not an expert, but as far as I can tell, not that well in those countries, as you've asked about. The economy's a bit of a mess as well, and in particular Italy, I feel, is a bit abandoned by the rest of the EU.
They're smashed by this thing.
Yeah, and they propose things to try and help to the EU. So there's these things called Corona bonds that they put forward to the EU, which are debt instruments that would allow single currency using nations to borrow collectively. However, the idea has kind of been shot down consistently. But I think it's like Germany and Holland. I think that, weren't happy with that. So yeah, those are those countries. Then there's kind of a second group, which is Germany, Sweden, Austria, Norway, countries like that. They've had much lower morbidity and mortality, and the testing and tracing protocols seem to have worked much better. As far as I can tell, people are not so sure which specific factors have led to different outcomes at the moment.
Really?
Well, it could be that I've seen different theories thrown around, and I wouldn't want to sort of pass judgment myself because I think it's a huge area, but it could be sort of things like the size of households, structure of the healthcare system, because they all have slightly different healthcare systems. An interesting one is the number of ethnic minorities, because you've probably seen ethnic minorities are disproportionately affected by COVID-19, sort of people from South Asian descent. Sort of number of intergenerational households, being that, like, you know, if you've got elderly and
pass it on,
exactly, and like government policy. But yeah, super unclear as of yet.
Yeah, it's so complex to wrap your head around. I'm glad there are way smarter people working on this thing than me, because it's hard to wrap your head around this sometimes. What's the feeling in the UK at the moment of just generally for the people?
I think a bit of relief after the whole past the peak Boris Johnson announcement, and people feeling perhaps the worst is past. The big concern, I think, though, is how society is going to learn to live on with the new normal. There's obviously a lot of fear, a lot of anxiety that new waves of COVID-19 cases, as deaths are super high still. So today, for example, we had another 205 deaths among people diagnosed with coronavirus. And I had a look at this before. We have a total now of 23,150 deaths reported in hospital in the UK, which is obviously pretty big.
Yeah. Are the hospitals coping? I know the NHS was under pressure before COVID-19. Have they got enough PPE? Have they got enough resource and funds and people to manage this whole situation? And has the situation meant there's more hospitalizations or less because they're not taking as many people who might be needing surgery per se that can be put off for a while?
So lots of questions there that you've asked. So kind of in terms of coping in general, from my specific experience, so what they were doing was ICU was understaffed because they had an increased demand in terms of patients and lots of people off sick, as you can imagine. So what was happening was they were planning to second trainees working in some of the surgical specialties to if things got busier to work in ICU. And so that was why they asked like orthopedic people like myself who currently doing that as a rotation, and I went and did an ICU training so that if I'm needed to be pulled across, I can be. However, they've actually not had to ask for much support from those. They did initially, but not for a while. They said they've not formally seconded us. However, a lot of the orthopedic nurse practitioners, so they're kind of the step up from nurses. They sometimes they're prescribers. They have slightly more clinical skills than nurses. You might have them in New Zealand. I'm not entirely sure. Probably. I
don't know health system too well.
Yeah. Anyways, so those kind of healthcare professionals are apparently they're mostly working in ICU. So we're kind of filling in some of the ward work gap with those professionals moving to ICU. So that kind of helped cope, and then obviously they've not had to use all the resources they put to one side, so that's positive. In terms of changes they made to actually help prepare, so I think, as I mentioned before, they separated the wards into COVID-19 positive, so dirty and clean, and then you've got this whole system where patients go to SDU and wait for the results of the 2 swabs before they're admitted. So that's good because it's allowing us to kind of, rather than allowing cases to spread amongst wards, it's keeping a lid on that a little bit. They did things like they set up a new minor injury service that's consultant or registrar led, so senior doctors basically, and that sped things up in terms of the junior doctor workload, because normally when I'm on call on orthopedics, I take all the referrals in to the hospital for orthopedic problems, but now they've got this service where they direct people and they'll see a consultant. They can be seen much quicker, so that's meant if we've got sick patients on the ward, etc., we're more free to deal with that. They closed main theatres as well initially because they had to turn the operating theatres into an extended intensive care for more patients needing ventilation.
Oh wow.
Yeah, so obviously we've got far fewer people going to surgery because of that. And actually sometimes I've had on-call shifts recently where it's pretty busy and you see stuff where you're like, this doesn't wait, but it kind of has to. However, having said that, as of Thursday, I spoke to one of my junior doctor colleagues who's doing a placement in anaesthetics, and she said that it's 9 patients in ICU. I work at quite a small hospital, but that's pretty good. And they're no longer having to use theatres. So that's kind of shows that we are coping. Random point that I think is interesting to mention. You expect there to be a less trauma to deal with during lockdown in terms of like orthopedic injuries. Not entirely true. People at first massively avoided going to hospital, but then as time's passed, there's been this influx in DIY, outdoor activity, bird bite related injury.
People are just bored.
Someone came in with a seagull bite, and we were flummoxed. But apparently, it's because less people are going to the beach and feeding the birds. Anyway,
that's crack up. Do you think that? So obviously, there's been a rush into hospitals with COVID-19, and
you asked about PPE as well. Sorry.
What's that?
You asked about PPE as well.
Oh, PPE. Let's hit that.
Yes, sorry. I'll tell you about that.
It's all right. It's all right.
So it's an interesting one because I did read an article in the Financial Times that said NHS was coming within days of running out of key items of PPE because they'd had an internal assessment, and apparently that's what it showed. And I think there are differences in availability of PPE across different hospitals in the UK. And I can't speak for places like London where I think it's been much worse. But in terms of my experience, I've had adequate PPE per the Public Health England guidance, but I have some issues with this because it states that when you're looking after a patient within 2 meters who's COVID positive, you have the usual mask, eye, face protection, and gloves, but a plastic apron's sufficient. But actually, the WHO guidance says mask, goggles, gown, and gloves for all kind of COVID positive patients when you're caring for them. So there's a lot of kind of campaigns at the moment going on, and there's one called Every Doctor, and they've got a petition. This is a bit annoying because I think I've spoken to some of my kind of seniors in respiratory, and they were saying that we could really be doing with some upper arm protection when you're caring for a patient within, because as you can imagine, the virus lasts on soft surfaces if you're examining a patient within 2 meters and you've got, your scrubs on or whatever, you still could get the virus on you. So I think that's less than ideal.
Are health systems taking shortcuts because they're under-resourced, do you think?
I mean, I don't know. I think they're doing their best in an unprecedented situation.
Yeah.
And I think this is the guidance that Public Health England has issued. I think they're also dealing with supply chain shortages. I don't know. One thing I will say is that the amount of things that have happened because people have donated them to hospital is slightly concerning. So there's some fun innovations that have happened with people trying to scale up PPE. One of them being 3D printing. And I actually, a radiologist at my hospital gave me a 3D printed visor that was made by his friend's company or something that's just been donated to hospital. I have it here if you want to see. Here, I'll show you. Where is it? Somewhere in this. And apparently it can withstand very high temperatures in an oven. Although I've not actually tested this theory, but there we go. So yeah. Jase, I think you have frozen.
Holy moly, just had a mare with the tech. We'll try and get Tash back on for everyone who's watching. We'll flicker a message now. Sometimes when the curtains roll up, tech just fails on you. We'll get her back. I'll just message her now. I kind of like minor dysfunctionalities. It makes it a bit human and all you can do is laugh at it. It's part of the gig. We've got it back.
Ah, hello.
Tash. Sometimes the tech just blows up. Yep, we're back. We were talking about PPE.
Right. I have no idea what the last thing you heard me say was.
That's all right. That's all right. We can move on from that. Go to something a little lighter. What's on your post-isolation bucket list? What are you going to get up to after all this dies down?
Oh gosh, that's big. In terms of, you mean like once all the lockdown measures have gone and stuff?
Yeah.
I would have said like travel and things like that, but I've heard estimates that we're not going to be able to travel for another, up to a year, and in terms of borders being shut. But I do have, so I've talked a lot about health and health inequalities, but yeah, a wide range of interests outside of that to keep me sane. So I'm very much looking forward to hopefully being able to go to concerts again in the theatre. Those are things that I miss. And also, I'm a bit of a, if I do say so myself, a very, very amateur triathlete. So it'd be fun to maybe start entering some of those
Awesome.
again.
When did you get into that? You weren't doing that when I met you in New Zealand, were you?
Yeah, it's a recent thing. A very recent thing.
Go you.
I started it last year, actually. I did a local one near my family home. In the work up to, I did the London triathlon, and I did some others as well, which was fun, and around the northeast of England. I've only been doing shorter distances for now, but I'm hoping to, like, sprint distances and slightly over sprint distances, but I'm hoping to sort of move up to an Olympic. Yeah.
Crazy. You always aim for the top. That's what I love about you. Natasha, it's been a pleasure having you. Sorry about the tech.
It's all good.
Sometimes when the curtains roll up, you just have to manage these things. The tech isn't dealing with the whole lockdown situation either too well. But
Yep.
Always a pleasure to catch up with you. If you ever need anything, reach out. You gave so many insights into what's happening and behind the scenes in the NHS, what's happening with WHO and the science. So thank you for that, and I'm sure the viewers appreciate it. We'll catch up soon.
It's very much an honour. You've had some really cool guests on, so it's fun to be part of it.
You're right up there. Awesome, Tash. We'll catch you soon.
Thank you. Stay safe, New Zealand. And yeah, you as well, Jason, and hopefully talk soon.
See you later.
Bye.
Tash, what a powerhouse. Athlete, doctor, running the world, saving lives. Doesn't get much better than that. Tech issues in the middle there, but had some great talk about what's happening medically and behind the scenes. That's all from me for today. Tune in tomorrow. And the rest of the week we have awesome guests on. So just if you like what's coming up, jump on, see what we have to say, and ask questions, and you'll get answers. All right, that's all from me. Peace.